Good morning. Good morning. Welcome, everyone. We start on time, and I want to thank you for getting here timely. On behalf of the Emory Goizueta Alzheimer's Disease Research Center, I'm going to do a little bit of housekeeping, but in front of you, you have a stack of papers. There's one form I want you to take out and complete, whether you've been here one time, this is your first time, or your fifth time. We just ask that you complete the photo release form. If you do not want to be videoed or recorded, we just ask that you sit in the back here on the wall. We will make sure we do not capture your image. But because, again, this is history in the making, literally. If you look around the room, how often do you see this image? And so because we've done such a great job and you all have been so responsive, we want to absolutely, as best we can, capture what is happening right here live. So if you'll complete that form, turn it over and put it in the center of the table, we will appreciate it. All right. Thank you. All right. So a little bit of housekeeping here. I'm going to tell you what you can expect today, again, if this is your first time or your 10th time, because we have been hosting this program here at the Emory Brain Health Center on site since July of 2022. And so you're going to have an exercise demonstration. We have lots of health information to share with you. For the most part, we want you to fellowship and network. Okay, so greet and meet with your neighbors, but most of all, we want you to take lots of notes and implement what you learn, right? So as I mentioned, we started this program in 2021. It was virtual. We had, I think, like 30 men online with us. Last month, we had about 160 men in the room where we talked about veterans benefits. And even if you weren't a veteran, we heard your feedback. You said, I know someone who could benefit from that information today. So a little bit later, you're going to hear from Dr. Parker. She's going to introduce Dr. Jeroson Williams, who is our featured presenter for today. But because 40% of you all are new and we are at the Brain Health Center, we have to make sure everyone is kind of on the same page. So Dr. Parker is going to give about a 10-minute overview about the difference between dementia and Alzheimer's. You all completed a pre-event survey and you have lots of questions. And so we want to address those questions. We'll have a little bit of time for Q&A after that. We won't be able to get to every question, but for the most part, we'll get to as many as we can. Okay. All right. The other thing that people often say is, what else are you all doing outside of this program? Because my friend wasn't able to make it, or I learned so much, I want to share this information with others. Well, every Tuesday, we host what we refer to as our Brain Talk Live program. It's on Zoom and it's been going on, since March of 2020. So if you go to our website, you can register. Once you're registered, you're good to go. Jason Cobb was with us this Tuesday and he talked about kidney disease, leaky bladder, protein in your urine. So if you go to our YouTube channel, you can go back and watch that program, but it was phenomenal. We had over 50 questions that he got bombarded with, and that recording is on our YouTube channel. Okay. Secondly, we do a lot of outside of doing programs here on campus at the Brain Health Center. We're out in the community quite often. And so I want you to take note of this program that's happening on March 18th at Greenbrier Mall. And Dr. Parker will be there as well, but we are going to have our colleagues from the Atlanta Black Nurses Association doing memory screenings on site. So if you have never had a memory screening, or you want to kind of know what is that, or how do I address a memory screening, here's a great space and place to get a short intervention, a short diagnostic tool on site with our nurses at the Links Wellness Expo. Okay. All right. So our next program is April 13th. We've been doing this every month. We won't stop until they tell us not to do it anymore. Okay. But it's the second Thursday of every month at 11 o'clock. Okay. Dr. Faulkner will be our featured speaker in April. Please pre-register, because last month we had to turn people away and we don't want to have to do that. So it's first come, first serve. If you know you're not coming, go ahead and cancel because that spot can be made available for someone who is available and plans to come. But Dr. Faulkner is a urologist.
And we're trying to see if we can even get some prostate cancer screenings done during the program or prior to the program. So be on the lookout for the emails and all the communication that we send. If we don't have your email address, you're like, I emailed and I probably put, Dmail instead of Gmail. Just make sure we have your correct email address if you're not getting communication from us. All right. So one thing I'd ask, you would silence your phones. A lot of phones go off during the program and we pick up that feedback and it takes us forever to edit videos and cut out all of that. So if you don't mind silencing your phones, if you need to take a call, just step out. In the back of the room, there's 2 double doors. The restrooms are to your left as soon as you exit those doors. As we said, we always practice what we preach. So we begin with exercise. We have an exercise demonstration with John Lewis. John is actually across the world, literally. He's in Africa right now. So we have a recording of him today, but it's almost like he's in the room. I would just advise you, participate at your own risk. If you haven't been physically active, he kind of goes fast, he kind of goes slow. It's lots of fun. You don't have to do it, but we want to practice what we preach. And we're constantly telling individuals to be active, to get your 30 minutes of aerobic exercise every day. So this is just a demonstration of what you can do from your home if you want to be active. This program is made possible because of philanthropy. It is not free. It's just not free. It's just no cost to you. So I don't like to say free. I just say we don't want to pass that cost on to you, but we want to make sure it's a good, high quality program for you. So again, if there's an empty seat, it's not our fault. We know life happens, but we want you here and present with us as we have these programs on a continuous basis. All right. I want to just thank all of our team members, all of the volunteers. Mr. Michael, raise your hand. He was here with us yesterday. We need volunteers. This is not an easy feat. We don't have a ton of staff to help us do this. We just have 4 dedicated staff that do this 100% of the time. But as the demand continues to increase, we need more support, more manpower. So if you have free time the day before the program or even after, help us clear the table, take the packets with you if you see extra packets, because there's someone that is going to benefit from the information we share today. Sharing is caring. Make sure you share that information. All right, I've already said take notes, implement what you learn. The yellow form, if you have already completed a yellow form, that's what we refer to as our research interest form. That gives us permission to contact you if you want to participate in our Brain Health Center research. All right. If you've already filled it out, don't fill it out again. That makes extra work for us. You're in the queue. You guys have been so responsive. They're booked 2 months out. So bravo to you for doing such an amazing job. They're scheduling, they're catching up. But as you know, even in the healthcare system, it's taken a while to even get medical appointments, right? So we are working with our research team to begin to try to operationalize that a little bit better. But if you have a modicum of interest and a little bit of interest and you're just on the fence, go ahead and fill the form out. Someone will help you navigate our research process. Okay. There's a post-event survey. We usually do a drawing at the end, have lots of fun, but we take your feedback to heart, constructive feedback, because some of y'all said some things I was a little, somebody called one of our colleagues a Karen. So we want constructive feedback and take time to complete the survey over the next hour. But for the most part, complete that survey. We'll do a little drawing. I think we have some $50 gift cards, $100 gift cards, and some $25 gift cards. There will be a Q&A. We can't get to every question. We're going to do our best to toggle the room and get to as many questions as we can. But because you have so many questions, inside this particular document, it's white and has our Emory logo on it. Inside, there's a flyer and it says, it's good to have questions. We're going to host a Zoom session. You need to pre-register for it. You'll see our colleagues, Dr. Flowers, Dr. Dodd, Mr. Graves, Mr. David Dorman. They're going to be on the call to respond to some of those questions that you probably still need some clarity on, but you need to pre-register for that particular program. All right, and then don't forget, take a flyer with you for next month. We'll be hearing from Dr. Faulkner. Okay, that's all the housekeeping I have. Lots of stuff to cover, but with that, we're going to turn it over to John Lewis. Remember, go at your own pace, and then I'll come back and introduce Dr. Monica Parker to you all, and then we'll proceed with the rest of our program. Thank you.
Hey, hey, hey!
You need a
I
little
want to
nose.
say welcome.
On your chair, so
Remember,
careful.
the rule is go at your own pace. If it's something you don't want to do, don't do it. But also, I want you to remember, you cannot cheat me. I want to say welcome to all you men for doing something good for yourself today and every day. Today, we're going to work on that entire body. So I need you to get your minds right, get ready to move and groove, get your little space, and let's go. Hey, y'all, we got this thing. Come on. We want y'all to join on with LTV and follow along with us. Come on, y'all. We're going to warm it up. Hey. Whoa. Come on now. There we go. Come on. Here we go, y'all. Come on now. Come on. Get on in the groove. Get in the groove. Come on. Watch. Giving invitations to everybody. We warming it up, everybody. LTV is hot. Oh, get in the troubles. Let your mind have. Let yourself go free. Get free what's happening. All right. Perfect. Yeah. Do that. Give it a show. Give it a show. Let's tear the roof off if we can. Let's boogie down until the end. Watch it now. Hang on. They belong to yesterday. Listen to the music that we're playing. Because the song has been designed for the people who like it. In mind. It's not a little way for everyone to sing. So clap your hands and make it Hold it! Come on! Get it! Get it! Woo! I don't think there's anything better. Get it! And a crowd of people singing all together. And it especially makes them feel so happy. When they all join in, start to happy. Because the song has been designed for the people who like it. Great job. We're gonna stay working.
Yeah.
I need that upper body. Come on. Push it. Come on.
I'm your mama, I'm your daddy, I'm the nigga in the panic. I'm your doctor when you need. Want some coke, have some weed. You know me,
Come on now.
you been
Come on. Keep it.
I'm your pusher man,
Let's go.
I'm your pusher man.
Come. Come. Let's go.
Ain't I clean, bad machine, super cool, super clean, feeling good for the man, super fly, you're not stand, secret stash, heavy bread, baddest bitches in the bed. I'm your pusher man,
Come on.
I'm your pusher man, I'm your pusher man. Solid life, crime.
Let's go.
A man of all circumstance, a victim of yellow demands. These people if you stop, and I'll make you trip for the
Keep it
week.
going.
Insecure from the past. How long can a good thing last? Got to be mellow. Gotta get mellow.
Everest. Great job. I need you up. I need you up for this one. Let's go.
But I know you see me in it.
Just get your space.
You had me come through it.
I need you to get this step.
Doing my thing. Doing my thing. Doing my thing.
Let's go. Come on now.
Doing my thing.
Get.
Doing my thing.
Oh.
Doing my thing.
Oh.
Doing my thing. Doing my thing. Doing my thing.
Hey. 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 Get low. Get low. Get low. Get low. Get low. Get back.
I'm on another level, should've never bought that pill back. Cause I done threw back my two. Pass up, I pop four. If you ain't in that Jigga City, you wouldn't know how they go. So I say I'm a gangster, but I just ain't no fake. If you ain't come to do the dance, why you step on the I'm doing my thing. I'm doing my thing. Why you pulling on my pants? I'm doing my thing. Why you pulling on my pants? I'm doing my thing. I'm doing my thing. Why you pulling on my pants? I'm doing my thing. I'm doing my thing. Why you pulling on my pants? I'm doing my thing. I ain't lying, I can't chill, but wishing for will. You get up, you think you tough, you shouldn't have took that part. I heard you dissing in your song, well, you gon' miss your deal. The choppers eat you like a meal, spin just like a drill. I'm in that water like a seal, but I'm straight from the field. I got some shooters that's on go, I'm wishing for will.
Come on.
You
Go.
always just
Go.
drink them
Go. 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 Go.
I Share my trust, stepping on my lips. I'm in this door. Back it up, back it up, back it up. And in my pocket, I got bands, but this ain't from no deal. Back it up, back it up, back it up. You gonna let me do it, then that's just how I feel. You back it up, back it up, back it up. Hey, you hit my block, I got the one that didn't tear up the wheel. So let's go ahead and go, go, I'm not finished with y'all. We need to slow it down. Great job, great job. Here we go. We done got that cardio up. Let's finish up. Come on. The way it broke my heart. Shed a lot of light through the window. Yes. Come on. We're finishing up now. Come on. Thought we had it so good. Rest. Really saw this coming. Oh, why you got to be so cold? Why you got to go and cut me like a knife? Come on. Put on a bone. Rest. Go, go! Yeah. Do you know you left this hole? Come on! Right in the middle. We get no sounds! Woo! Oh! Rest! Got to be so cold! Twist that waist! Get it! Get it! Get it! Get it! Go! Go! Come on now! What am I supposed to Come on now. Say? Anybody ask me about you? Guess I'll tell them I Watch this. Got you. Watch this. Hold it. Listen, y'all. How am I supposed to live? 5, I build my life. 4, 3, Settle my 2, 1. Let's go. Oh, why you got to be so cold? Why you got to go and cut me? 5, 4, 3, 2, 1. Do you know you left this hole? I want to say thank you, thank you, thank you. Remember, do something every day for your temple. I'm John Lewis, and see you later. Bye.
And your water should be almost finished. Okay, you've already gotten the recommendation is 30 minutes of aerobic exercise today. You already have 14 in. Okay? All right. So next up is the director of our outreach, recruitment, and engagement core, as well as our minority engagement core, Dr. Monica Parker. She's been a practicing geriatrician since the last 30 years. So when we talk about having expertise, but also being an ally for people that look just like you and me in this room, this is the person we call upon. So please welcome Dr. Monica Parker to the stage. Thank you. Dr. Parker.
I just want to say thank you to the men who sat down and didn't move their arms trying to be cute. That's one thing. This is a
safe space, so we don't really care how you move. We just want you to move, and that's why we have John doing it to music that you like, right? Right? You gotta keep moving. All right, so we did that just because, and I think the thing that's important is I'm out of breath. I'm always out of breath. But you can get a whole workout by sitting in your chair. Don't you feel like you got a little bit of a workout? So workout doesn't necessarily mean that you join a gym. It just means that you put on your shoes, you walk to the corner and back because you don't do that all the time. It means sitting in your chair, doing what John did, or even dancing. I got it. I think it's working now. So with that being said, I want to say, first of all, thank you to all of the men who are repeat players. Give yourself a hand. We've got a bunch of new people here. I think what Cornelia told us that we have about 37% of you who are new. Who's new here? Who's never been here before? Yay, give it up. So our salesmanship is really trying to get you to participate in clinical research here at Emory or any place else you choose to, simply because research participation for people of color is important. It helps you become a better consumer of healthcare, helps better inform how decisions are made about our health. A lot of discussion about health disparities in communities of color, but a lot of the disparities are related to the fact that we're not participating in what's going on to develop treatments, therapies, diagnostic tools. So our game over here is brain health and Alzheimer's and related dementias. If you're one of our participants and ambassadors, we promise to help you navigate the system with the resources. And that's why we keep putting them out there for you every time you come to something that we do. So before I get started with my talk, which is all about more education, how many of you brought a guest? Raise your hand if you brought a guest. Okay, so where are our assistants? If you brought a guest, I need you to stand up so we can identify you. I need you to complete this form. Stand up. Let me count. I need to see you. This is real important. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. I see 15 people brought a guest. So we need 15 sheets completed. If you brought a guest, I counted 15. So Cornelia, who's going to collect these when they're completed? Okay, we'll collect them as we go through the Q&A. All right. So if you brought a guest, this is real important because I just want you to know we're going to give you something. We're going to reward you for your efforts, but we really appreciate your publicizing the men's health discussion group on the second Thursday of every month. And we really appreciate your being here all together. So a couple of acknowledgements. Cornelia said that these things are free to you, but they are not free. They are made possible by philanthropy. And a lot of times when we start talking about philanthropy, that's somebody else donating to a cause and making things possible. So we have a lot of philanthropists in the city of Atlanta, many, but there's one that I think is really important for you gentlemen to know about. It's called the Jarvis Foundation, Ken Jarvis Philanthropic Foundation. For the representatives who are here from the Jarvis Foundation, stand up, please. I know you're here. I saw one of you. And UPS Foundation, Ken Jarvis Foundation, the UPS Foundation. These men are really important because these are African-American men who are contributing to the philanthropic cause, if you will, to further the education and support the education of minorities in the College of Medicine and in our different programs here. So I want you to know that we have Black philanthropists who support our cause. So I want to say thank you to those gentlemen, and there'll be more as we come along, and we'll introduce you to more as they go along. But I also want to acknowledge some of the people who've helped us with our outreach consistently. Dr. Clinton Dye, former Urban League Director for the City of Atlanta. Dr. Cornelius Flowers, retired cardiologist. Emory Healthcare just retired. Mr. Karen Graves, Atlanta Duffers. Where's Albany? I saw him walk in here. Albany Price, 100 Black Men of America. I think I got everybody. Did I, Cornelia? If I didn't, ooh, I got them all. Okay. All right. Just making sure that you knew that there were some very important people that are important to this event and have helped fund and finance these kinds of events for us throughout the community. So because there are 37% of you who are new and first timers, I want to give you kind of a little bit of the most frequently asked questions when it comes to Alzheimer's and brain health. What's the difference between Alzheimer's disease and dementia? The big thing that you need to know is they're all really much the same thing. They end up the same. You end up not being able to do anything for yourself and somebody else has to help you do it. But what you need to appreciate is that this brain dysfunction can be related not only to Alzheimer's, but to other things. Maybe it's a stroke. Maybe it's uncontrolled diabetes. Maybe it's chronic alcoholism. Maybe it's head trauma. Maybe it's an untreated and unmanaged HIV infection. Maybe it's a plain infection. So brain dysfunction or dementia can be caused by a number of different things. Alzheimer's is one type of dementia. The thing that's important, and this is what I have to tell you as a primary care doctor, is that dementia has, I like to call it a many splendored thing. There are different things that cause brain dysfunction. It's really important for you to partner with your primary care doctor so that you can sort out what can be fixed and what can't be fixed. Because one of the things that we don't talk about a lot in our community is depression. Unmanaged depression looks like dementia. Okay, you don't need a specialist always to figure that out. I need to go to the best specialist. I need to go to the Mayo Clinic. I need to go to the Harvard. I need this. No, you need to talk to your primary care doctor and talk to them about what you're seeing and make sure that we've eliminated all causes for why anything that's treatable, let me put it that way, that might be relating to the symptoms that we're seeing. What are some of the health risks associated with memory loss? Everybody thinks Alzheimer's is just memory loss. Well, it's brain dysfunction. Your brain helps you do a lot of stuff. And talking about memory loss is not really giving you the right picture or the complete picture. When your brain isn't processing information well, you don't remember stuff. You can't do stuff. You might not be able to move. The kind of stuff I'm talking about is stuff that all of us did today. You can't remember how to wash your face, brush your teeth, how to pick out your clothes and put them on. Maybe you can't remember where to pee and where to poo, right? I mean, some of you are dealing with that. You have family members. I know you do. You might not want to talk about it, but that's a sign of brain dysfunction. Some kind of dementia is at play. So when people confuse you with who your brother, your sister, or somebody like that don't recognize you, don't recognize where they are, forget how to do things like drive or forget their direction. They've lived in, I used to practice in Social Circle, Georgia. There's one, there was then one traffic light. You get lost in Social Circle, Georgia, you've really got a problem, especially when you've lived there your entire lives, right? My point is, when you start to see stuff that looks abnormal, it feels abnormal, and it's not right, and you think it's going to go away, it's not going to go away. Talk to your doctor, make an appointment with that person, see the doctor, and evaluate for what might be going on. The evaluation process for dementia is not a 1 or 2 minute test in a doctor's office. It is a process. There's a medical process. We have to eliminate medical causes. There's a film, an image that needs to be taken of your brain to look for abnormalities in structure. So we're going to get an MRI of your brain or a PET scan, which is part of the research process, but an MRI of your brain, a CT scan. Then you're going to see the neuropsychologist, the PhD psychologist. You know, we made jokes about people who went to college and majored in psychology, right? It's a real profession. And clinical psychologists, I like to say, do the testing or the intelligence testing for older adults. Then after that, there are other tests that go along with it. One of those is analyzing cerebrospinal fluid to make sure that you don't have infection, because people who have meningitis will have signs and symptoms that look like dementia. People who have untreated syphilis, you know, we like to rear up and talk about Tuskegee. Well, unmanaged, untreated syphilis, latent syphilis, presents as dementia. And syphilis is treatable, right? Alzheimer's is not, but syphilis is treatable. So, is Alzheimer's disease hereditary? Well, there are more than 30 some genes that are associated with developing Alzheimer's. That doesn't mean it has to do with chronic trauma, depression, and all that other stuff, but there are underlying genetic components to just about every disease process as research goes along. There is a hereditary gene that's most commonly associated with Alzheimer's. It's called the ApoE4 gene, but there are 30 others. So don't get fixated on just one. As research comes along, we're gonna be more clear about the role of other genes that are play a role in developing Alzheimer's, okay? Is there a way to prevent Alzheimer's? We know that 60% of all dementias, and you remember there are several different types of dementia, right? 60% of all dementias are preventable. How are they preventable? Becoming literate, exercising. We make a big to-do out of having John here exercising. Well, a 20-year history of uncontrolled hypertension, diabetes, anemia, chronic kidney disease, COPD, rheumatoid arthritis are contributors to the development of a dementing disorder. Many of those things are preventable and manageable. Okay, who's more affected with Alzheimer's, men or women? Women. And it's not just because we live longer. There's something in our hormonal structure that makes us more likely and more susceptible to Alzheimer's disease. I didn't say the others, I said Alzheimer's. But women are more likely to develop dementia later on in life. But unfortunately for you all, we live a little longer too. Okay, so what is sundowning? My mother sundowns in the late afternoon. What is sundowning? That means that when the sun goes down, when it gets dark, people start to get a little bit confused, particularly if they have an ongoing neurodegenerative process. Alzheimer's is one, but maybe some others. They get very confused as the sun goes down. Not only do they get confused, maybe their behavior changes. Maybe they get a little belligerent. So sundowning is different for each person. Sundowning is managed differently for different people. And everybody who has Alzheimer's doesn't necessarily develop a sundowning effect. You know, there are behavioral strategies that we put in place to keep that from occurring, those behavior changes that are really something that disturb the quality of life for everybody else. So is there a cure for Alzheimer's? You've seen that there are 2 drugs that the FDA has approved for treating Alzheimer's disease. They're not treating stroke-related dementia. They're not treating HIV dementia. They're not treating chronic traumatic encephalopathy. Those 2 drugs may help people who have definitive Alzheimer's if it's administered soon enough. And soon enough is before they have debilitating symptoms. So if you can't remember stuff, I started to swear, but if you can't do stuff, this is not a medication for you. This is not when this medication should be given to you. This medication should be given to you when you have pathologic signs of Alzheimer's by, let's say, that brain image I talked about. You have a shrunken hippocampus, and maybe you have the genetics that point you in the direction of Alzheimer's, but you're fully functional. This is when those medications are most effective. The bad news for people that look like me is these drugs were not tested for us. So we don't really know how effective they really are for us. And unfortunately, the side effects that are associated with administering these medications for people who are not properly characterized are worse than having the dementia itself, maybe more catastrophic. So there are side effects associated with just about any medication that you take, even the antihypertensive and anti-diabetic medicines that most of us are on at this stage in life. How can I receive a PET scan as a research participant? We have 3 studies that do the PET scan. The thing that's important about the PET scan, it's the only FDA-approved device that actually definitively diagnoses Alzheimer's. So if you get a PET scan and it says, well, you don't have Alzheimer's, well, they're still crazy. So what did I got? It's like, I don't know. Nobody else does either. How do you manage it? I don't know. You know, we put stuff together to try to manage behaviors over time. And there are behaviorists who are studying how best to manage the behaviors of people with Alzheimer's. I participated in a study with some of my caregivers in something called the MAP habit system. We like to say that people who are having problems with their cognition or how their brain functions need a schedule. Just like you have a schedule for a 5-year-old, you need a schedule for a 65, 75, 80-year-old person who's suffering from dementia. They need to have a set time to do everything because that makes their behavior manageable. It makes them manageable. And more importantly, and this is the thing that a lot of us don't get, it makes them more comfortable with their environment. Some of the soft signs that somebody might be developing a problem with Alzheimer's are people not wanting to go places. How many of you have a relative who used to be real gregarious, used to be out and about, but now they want to sit home? Okay, you know why they want to sit home? Because they know that they have something wrong before you do. They try to hide it from you. So if I stay home, I know where the bathroom is. I know where the kitchen is. I know where my refrigerator is. I know where my snacks are. But if you take me out of my environment where I'm comfortable and you move me someplace I've never been, like a lot of us, since we're up, what is it? My son has a word, come up people. You know, we move from our little houses in the country or little suburban Atlanta in this case. And then we're going to move mommy and daddy to our big 10,000 square foot house. Look at my house. Look at all this. I'm on a golf course. Big deal. For your mother and father, those things are frightening. They're unfamiliar. They don't know where it is. So if you visit with them or they visit with you more likely, you're going to start to notice things. You're going to notice that they don't remember where to go to the bathroom. And because they're confused about where they go, they urinate and they defecate on themselves and they mess up your furniture. My mother-in-law used to do that. That was the thing that moved her husband and her son to put her in a facility. But what happened was my mother-in-law suffered a lot from depression. And once they got her depression straight, she came home. She got straight real quick. But the point I'm trying to make is for people who are having problems with their brain and the way they remember things, routine is something that's reassuring, that helps them stay independent and functional. And that's why we have to establish routines for things like that. And familiar environments, churches that they're used to going to, they're probably more comfortable going to, but they're not going to be comfortable going to a church they've never been to, around a group of people they've not been around. You don't bring somebody with dementia into a big 195-year-old or 80-year-old birthday party and expect them to know people. They're going to act out. They're going to be afraid. They're probably not even going to get out of the car because they're afraid. So you need to keep those sorts of things in mind. So with that, we're going to be talking to you today. I'm going to introduce today. Oh, Cornelia wants me to ask you have any questions right now. I have to defer to Cornelia because Cornelia introduces me, but Cornelia is the co-director of the Outreach, Recruitment, and Education Corps, as well as the Minority Engagement Corps. We've been doing this outreach since 2008, 2010, and it's grown. And we've gotten we've got federal funding, which means your tax dollars fund our research enterprise and our outreach. And last year, after all the work that we did, they saw fit to name us director and co-director. Didn't mean that we weren't doing the work. We always have. Somebody's always claiming credit for it, but we just finally got recognition. So kudos to Cornelia.
Dr. Parker, we do have one question here.
Okay.
Could you give me an example of how the lack of participation in clinical trials contributes to health disparities? And in particular, I'm not talking about access and services.
Okay, the question is, can you give me an example of how lack of participation in research contributes to the development of health disparities? And that's a really good question, okay? Partly because, you heard me talk about different types of dementia and the 2 drugs that have been recently released or approved by FDA. Well, they're not approved for all types of dementia. But more importantly, when it comes to people of color, there was not a significant number of Black people participating in that study to definitively say that this is just as efficacious in African Americans as it is in European Americans. By the same token, how many of you in here are hypertensive? Whole bunch of you, right? Raise your hand. Okay, I got it. Most of the medicines that you are taking for managing your blood pressure were not tested in people that look like you. They were tested in other countries. They were tested in other groups of people, but not necessarily you. We're giving you medications that we know work in one group, and we hope that it will work with you because we have not participated in those trials, and we're not really sure about what those different side effects, appropriateness, and other things are going to do for you. Dr. Williams is going to talk a little bit about some of that. But the important thing about health disparities, and to get to his point, other than access, is that we need to be a little bit more proactive about what it is we want from our healthcare system. So many of you in here have health insurance, have a doctor, and have a medical home. I just need you to make use of all the screening things and all the things that the United States Preventive Services Task Force recommends to keep us from dying of things that are preventable, like cancer, like heart disease, like diabetes, and yeah, hypertension too. Dr. Flowers usually does a really good talk on high blood pressure and heart disease, but those are things that we can manage. So disparities in healthcare result not only from our lack of participation in research, but also because there aren't enough providers and people that look like us that are serving the people, or taking care of the people, and participating in the research enterprise, conducting the studies that are important. There's something called what matters most when it comes to results in Alzheimer's research. I would say what matters most to people of color is, what is it that's going to keep me upright for as long as I choose to be? And you need to start looking at how you're governing yourself. So when they talk about wellness and what are we doing, don't get mad at a doctor because you've been diagnosed with stage 4 colon cancer because when you were 40, 50, 60, you didn't go get your colonoscopy. That's on you. That's not on the doctor. That's on you. Next.
I signed up for the research study in December, but I've not been contacted to let me know when it starts.
Latasha? Okay, this person's going to help you address that, but Cornelia alluded to some of that a little bit earlier. We do have a little bit of a log jam. I think, I want you to appreciate that you are a priority. And it's sort of like, I have 25 slots for the MRI this week, but I have 100 people that need it. Okay. So it's an embarrassment of riches. And I'm working really hard to find things that are what matters most to you. So maybe it may not be all of our studies. Maybe there's some other things that we need to work on that will help us be more healthy. And that's what I'm focused on, trying to help with. Next. Okay, gentleman with the cap in the back, Julius.
You mentioned medications for hypertension. I'm curious how many men in this room who are taking the high blood pressure medication lisinopril?
Probably a lot of you. Lisinopril does have side effects.
Yes.
Your point, sir?
That's the point. It has very serious side effects for Black people.
All that being said, and he brings up a really good point, lisinopril is still one of the better medicines for managing hypertension in people of color, but lisinopril isn't the only medicine that has side effects, okay? Any medicine you take has a side effect. Maybe the side effect is 0.1% of all people who take the medication who will experience it. But you may be that 0.1% who experience the most dire side effects. So I'm saying that to say that this is not an excuse for you not to take lisinopril. If it works, it works for you. If it doesn't, it doesn't. Everybody's an individual, but doctors prescribe medications consistent with what they've been trained to do. And we can't foresee all of the complications.
Okay.
But you need to be aware and read the package insert.
Excuse me.
I've read that you mentioned high blood pressure, but I've mentioned that beta blockers are problems with people who get dementia and Alzheimer's. And those are the drugs like atenosol and clobetalol and those kind of drugs. And a lot of us are taking them, like myself.
Okay. The question is, I've heard that beta blockers are a problem and can contribute to the development of dementia in Black people. Dr. Flowers, I just want you to address the question about beta blockers, please.
As Dr. Parker said, every medication that you see has some side effect in some people. Here is the bottom line. Anything that you do or take If the benefit of the medication outweigh the risk of the medication, you are ahead of the game. For instance, the ACE inhibitor question. Less than 5% of people on ACE inhibitor are going to have problems. I take an ACE inhibitor. That's what lisinopril is. It might make you a little cough, might have angioedema, which make your face and lips swell, but that's only happening in what? 2 out of 10,000 people. Now, the beta blocker thing, beta blocker does cause some depression of your memory in some people. It may make you lethargic. But if you have that derived in your situation, then your doctor can adjust you and put you on a non-beta blocker medication to control your blood pressure. There are at least 5 or 6 classes of medication you can be taking.
Okay.
Does
that answer the question, sir? Okay. Is that it, Cornelia? Okay, Cornelia's pulling the plug. All right. So at this time, okay, I need to, those of you who filled out this white form, hold it up so we can collect it, please, because this identifies who gets their reward for bringing somebody. Hold your little white piece of paper up, please.
We got most
Has
of
to
them.
collect one.
Collected most of them. Got them all.
Okay, she said we think we've gotten them all. Now, for the main event. Okay, I'm really excited because the young man I'm about to bring in front of you is named Dr. Jeroson Williams. He is a surgeon here at Emory. He's training to work in vascular disease. He'll tell you a little bit more about it. So I'm going to say this before he gets up here to tell you, and I don't need you to repeat it, Jeroson. Jeroson's a graduate of Morehouse School of Medicine. He is a member of Omega Psi Phi fraternity. Don't be dog calling. And, oh, please. I'm in a sorority, but you don't hear me doing all that. But I'm really proud of Jeroson because his mother was a classmate of mine at Fisk University. She was a little behind me, but more importantly, her mother was way ahead of me as a Fiskite. And he has an uncle named Kevin Church, who's fine as and when we were on campus, Kevin was one of the most popular people because he was so cute. But I'm really proud to introduce Dr. Jeroson Williams because he's a legacy, an HBCU legacy. He's a proud African-American man. His mother made his grandmothers a part of our research studies. And I'm happy to say that both of those ladies were my patients. So at this time, I'd like to introduce you to Dr. Jeroson Williams.
Thank you for that introduction, Dr. Parker, and thank you for all your efforts with both of my grandmothers who are now gone on to glory. My name is Jeroson Williams. I am a surgery resident here at Emory in the Emory systems, which means I work at all the hospitals in the Metro Atlanta area. You may see me at Grady, you may see me at Emory Midtown, you may see me at Emory Main, you may see me at St. Joe's, Johns Creek. I don't sleep much. We're always working, okay? I just want to tell you a little bit about myself because I was just kind of observing the room and I see my uncle in here and things like that. And so I know a lot of the men here have contributed to the community that built and raised me. And so I think it's my responsibility to contribute to the community environment of medicine that's going to take care of y'all, okay? So I'm a graduate of Westlake High School. I went to Morehouse College for undergrad. I went to Wright State in Dayton, Ohio for medical school. Proud member of Omega Psi Phi Fraternity Incorporated Psi Chapter, and I'm now here, now here at Emory. Like I said, I just want to highlight some important people to me. The man here barefoot who would probably kill me for posting this picture is my dad, Jerome Williams. He's also a graduate of Morehouse College, and then the man sitting next to my dad in the cream vest is my uncle Clark, who just passed 3 weeks ago. From bladder cancer and pancreatic cancer. He was a couple years older than my dad, kind of mentored my dad and was one of his best friends, and is as smart and as well off as my Uncle Clark was. I still think he struggled with understanding a lot of the components of his health and the complexities of his disease as he matured in years. So I can tell you that my dad has me, right? I'm always going to be there for my father, and I'm always going to review all of his medical information before anyone touches him in a clinic, before anyone touches him in the ED, before anyone touches him in an operating suite. I will be there to review what's going on. The question is, who do you have, right? And so the answer is you. You have you. And so today's talk is going to be taking control of your health. I'm going to show you how to be a good surgical patient. So those are the folks I work with primarily. How to be a good patient in general. How to be a good patient advocate for those folks here who are with family members, or if you have wives, spouses, or whatever else, how to be a good advocate for those folks. How to be proactive about your personal health. We're going to do a live scenario, and since I see my uncle here, he's going to be my guinea pig. And the goal is I don't want anybody to fall asleep. I don't want you to lose. I got my Falcons logo there because we know a little something about losing. I don't want you to lose out on any information. Okay. I might have to take from Mr. John Lewis and ask people to do some push-ups if I see him falling asleep. Does anyone know who this is? That is true. He is a basketball player. This man was the #1 pick in 2013, Anthony Bennett. He's not in the NBA anymore. You don't want to be Anthony Bennett. Anyone know who this is? He is the greatest basketball player of all time. We can argue about it afterwards. Anyone know who this is? Names on the back. He was initially called Maple Jordan. They thought he was going to be the next Michael Jordan when he got drafted, #1 overall. He struggled for some years, got traded to the Warriors, became an all-star, won himself some rings, right? That's who I kind of want y'all to be. I don't expect you to be LeBron James of your health. I'll be the doctors and things like that. I paid a lot of money in loans to know as much as I do right now, okay? What I want you to be is I want you to go from someone who has potential, because every man in this room has potential to be able to take care of themselves and understand their health and become an all-star in your own health, okay? So that's the goal here. And so I have a lot of pictures here. I have a lot of acronyms, and you can scribble down some of the acronyms. I'll make sure Dr. Parker is able to distribute some of the slides and stuff going forward. But this is going to be my quick and dirty, this is, you're going to the ED, quick and dirty, like what should I be thinking about, what's happening, what's going on in this hospital room. So the first thing to understand, and it's okay to admit this, is that medicine is complex. Very hard, it's multifaceted, and it's okay to say, Doc, I don't understand what you're talking about. You've said a bunch of words, said a bunch of big words. I have no idea what you're talking about. But the caveat to that is, it is your body and you deserve the clarity, right? You deserve the clarity. And so when thinking about some of these things, and shout out Eastside Golf, they're Morehouse alum who have this fashion brand. They partnered with Michael Jordan. They have a lot of golf apparel and trying to get more Black folks into golf. So I figured a lot of men here probably play a little bit of golf. So I put that on there to shout them out. But I have this acronym called PUT. And so it's purpose, understanding, time, and truth. So if you're in the ED and people are saying, I used surgery for this example, or they're saying, this is what you need to do. You say, what is the purpose? Why are we doing this? What is it going to help? Help me understand that, right? And then you start talking about the timing. How long am I going to be admitted as inpatient? How long until surgery? How long is the time of recovery, right? And then what are the expectations? Legitimately give me your expectations. What is the prognosis? Doctors can be like politicians, right? You can ask a question, and because we can't say anything definitively, we may give you a lot of gray. Try to pin them down the same way you would anybody else. Try to pin them down to give you a little bit more than the gray. They can say, well, lisinopril acts different in a different number of patients. Then you would say, okay, how many of those patients is lisinopril reacting differently in? And do I fit that side effect profile? You try to drill them down as much as possible with as much as you understand to get the answers that you need, okay? So pre-op, this is my wheelhouse here. Because when we take people back to surgery, or when I see patients who have had surgery, it is astounding to me how many people who had big operations have no idea what they had done. They have no idea what organs they have left. They have no idea why they have this big old scar on their abdomen. No idea. I see it every single day. And so I think, that's the issue with the physician-patient relationship. There's no way that I should be operating on anybody that doesn't understand what I'm about to do to them. There's no way I should be operating on anybody whose family members don't understand what I'm about to do to them. Okay. And there's no way you should let somebody operate on you and you not understand what is about to be done to you. Okay. And so this acronym, local risk, I think is very important. It's probably two major takeaways to take away from this talk. This is probably one of them. Okay. Location. Where is the surgery happening? Okay. What type of surgery am I getting? All right. And so let me backstep. So when I talk about location, we're talking about the anatomical site, like where on my body is this going to be taking place? All right. When I say operation type, is it going to be a removal of an organ? Right? Is it going to be repair of an organ or tissue structure? Right? We talk about complications. What can possibly go wrong? In the worst case scenario, what can go wrong? Is this a surgery that I can die from the surgery itself, not because of the anesthesia effects or anything else, but the surgery itself? Am I getting a surgery where is it a cabbage, where it's an open heart procedure? Are you operating near my aorta, where, if you make a nick on my aorta, I'll bleed out on the table? Or are you doing a hernia repair, where it's less likely these things can happen, right? Where it's a much lower risk surgery? Are you removing my appendix? Are you removing my gallbladder? Much lower risk procedure there. And then the morbidity, I think that's the one that people don't talk about enough. They can say, I can give you a surgery to correct your problems, right? But what will my life look like a week after surgery, 2 weeks after surgery, 3 weeks after surgery, 6 months after surgery, a year after surgery? Will I be able to walk? Will I be able to speak? Will I be able to meaningfully interact with my environment? Will I be the same? You're not going to be the same after any surgery. You lose something. But the question is, what are the potential side effects of this surgery, complications of this surgery that can rob me of my current status? Okay. The other thing is anesthesia. So like we said, every medicine comes with a risk. There's a lower risk associated with just local anesthesia, which means you're still awake. They maybe give you a couple pills of Ativan, so you're sitting there like you had a cocktail. You're kind of laid back and you're relaxed like you do for colonoscopy. And they do local anesthesia where they inject lidocaine and things in the local area where they numb it. You can't feel it, but you're still awake. There's a lower risk of death for those types of procedures versus where they have to put you all the way to sleep. They put a tube down in your throat so they breathe for you. There's a higher risk. It's a higher risk procedure than just local anesthesia. So understanding what type of anesthesia you're going to get. How long the surgery is going to take. The longer you're on the table, the higher risk you are. If it's a quick, easy surgery, they get you in, they get you out, you're at a lower risk. If it's going to be 10 hours, 12 hours, they're operating on your aorta and they have to do it open, that's a higher risk procedure. You need to know that. You need to be aware of that. And then like we talked about with complications, the recovery time, you got to know how long until I'm back to normal or my new baseline. Okay. Incision. Now, I've had some patients that have cussed me out afterwards when they see the incision that they end up with, even though I've told them beforehand that we're going to make an incision in your belly. We're going to go in, we're going to remove whatever we're going to remove, and we're going to sew you back up. And they get out of surgery, they see they have some big old staples there, and they see it looks really red and it's swollen, and they are mad because the bikini won't be looking the same, right, for a while afterwards. But you have to set expectations. You have to understand, ask your doctor what the expectations are going to be for afterwards, okay? And then lastly, who's performing your surgery? You got to know who's performing your surgery. The surgeon that's performing your surgery, their specialty, that kind of will give you an idea of their competency. All surgeons aren't created equal. All physicians aren't created equal. That's just the reality, okay? And so if you have the ability to be able to ask around about your surgeon, ask around about your doctor, then I encourage you to do that, okay? And then lastly, just making sure that you know your options. Know your options. And I can't, divulge like patient information, but I had a close family friend who had a major surgery a couple months ago. No longer with us, but had a major surgery a couple months ago. and the risks of that surgery were probably much higher than if she didn't get the surgery. Spent her last days in the ICU bed versus at home. And so sometimes, all surgery ain't good surgery. All surgery ain't good surgery. There's an opportunity for you to prolong life and potentially improve your life. There's also the opportunity for some harm to be done. And that's what you got to understand. Is there a benefit to doing the surgery? Okay. Any questions before I keep moving? What are your options? Yes, sir.
So he has said options are great, with a great extent. He knows he's still playing with you.
Yeah. So a good surgeon knows when and when not to operate, which is why you have to make sure you're picking the right doctor. You know when and when not to operate. You don't want to hurt your patients. We take an oath that says we do not want to hurt our patients. And if you know that a surgery is not good for a person, explain that to the patient. It shouldn't be, it's a two-way street. It's a two-way relationship. Okay. It's not, I'm telling you that you have to go to surgery and you go to surgery. It's, here are your options. If you go to surgery, this happens. This potentially happens. If you don't go to surgery, this potentially happens. And it's up to you to choose. That's informed consent, and that should happen every time. Yeah. I mean, I think that's with anything. That's with car salesman. That's with your mechanic. That's with your wife at home. Yeah, you don't know. You don't know.
So how do you choose the right doctor?
Yeah. Yeah, that's a great question. So now they have a couple options where you can look at reviews online. You got to be careful with some of the reviews because people that are motivated to leave reviews are maybe either super pissed off or super happy about the results, right? So it's never, what you really want is the majority of folks who come through this physician's office, what is their experience? That's very difficult. You have to hope you have a good relationship with your primary care doc, who you should establish, like Dr. Parker was saying, they have a referral pattern. They have a bunch of patients that they send to these different specialists. And so they know if their patients are coming back messed up, they stop sending their patients to certain surgeons. They say, every time I send my patient to Dr. Williams, they do fantastic. So they know that they're going to keep sending the patients to Dr. Williams because they're going to do well. And so, from that's how you have to have some sort of professional connection there to be able to determine whether or not someone's good or not. Yeah. Yeah, I agree. Yeah, I absolutely. I couldn't agree more. It's just like if you're going to invest, people get second opinions on their car. People get second opinions on, work to be done around the house. And there's nothing more important than your health. And so it's important you try to get a second opinion on that. I think some of the limitations are insurance, right? So they say you can only go to these select few folks based on your insurance. And so that's going to be a limitation. But of the folks you are able to select from, I think it's very important for you to make sure you're choosing the best possible person for you.
Dr. Williams?
Oh, yes, sir.
Could you address the post-surgical mortality rate between people of color and people not of color?
Yeah, no, absolutely. So I've actually done some research in some of these areas where, when you control for all the factors. So initially they say folks of color after surgery don't do as well because we have all these comorbidities, right? They say, we have higher blood pressure, we have diabetes, nutrition may not be optimized in some regard. And in some of those instances, absolutely, that does contribute to surgical site infection, that does contribute to readmission to hospitals and things like that. But there are instances in which when you control for all those factors, Black folks still do poorly after surgery. And there's really no good explanation for it besides racism, multifactorial issues from racism that contribute to why we do poorly afterwards. And unfortunately, there's nothing that we can pinpoint and say, if we correct this, everything else will improve. I think that's just the reality of our society and why you have, folks like me and folks like Dr. Parker working to kind of ameliorate some of those issues. The other thing, like Dr. Parker was saying before, is a lot of Black folks haven't signed up for clinical trials. right? The research, I keep moving.
No, go ahead.
Okay. But yeah, the research we do for the type of surgery that we're giving folks, type of medicines that we're giving folks are primarily white males. But we know that these things work primarily in white males. Black folks are reluctant to, be participants because of the history that we've had of being the guinea pigs, for a lot of white physicians over the years. And so I think as that improves, as we remove the stigma around that, as you have researchers like Dr. Parker and you have people like myself conducting some of the research you can trust, I would never make you, my father, myself a guinea pig, then we get to get a few more answers and kind of elucidate some of those things and improve those outcomes, those post-surgical outcomes.
Yeah.
That's the last question. I gotta keep moving.
Hey, I got two other brothers. That's the only ones left in our family. And we're all 2 years apart. My oldest brother got colon cancer, but it was addressed. They caught it in time. And they said it developed within 2 years. So had been getting colonoscopies every 3 years, every 5 years, and 3 years and 5 years. Okay, first ones that I got was I wanted the local because I wanted to see what was going on. I used to be a hospital corpsman in the Navy, so I wanted to see what was going on. So I had no problem with those, 2 or 3 of them. And then the next one I had to go to a different place and they refused. They only wanted to put you completely out so you couldn't see. That person nicked me. And so I had a urinary infection after that. So I'm not going back there again. But a friend of mine had the same thing and ended up dying from a raging sepsis infection.
Yep.
So my point is, propofol is what he was wanted to put me out with. He put me out with that. First of all, I want to know how safe that is.
Yeah.
And once once again, I have to get a colonoscopy again now, 2 more years. And I'm not gonna do anything but local.
Yeah. So yeah, like we've kind of alluded to that, different medications carry different risks. Propofol is a very strong anesthetic. It pushes you down, decreases your respiratory drive, so it makes you not breathe as much. If you hear about people who overdose on the medications, it's because they stop breathing. The drug tells their brain you don't need to breathe, right? And propofol is one of those drugs where it's very strong. It pushes you to sleep. It decreases your respiratory drive, decreases your blood pressure, all these things. And so, there's a risk associated with that. I think the risk associated with untreated colon cancer, if you don't catch colon cancer, is still much higher. When you do a colonoscopy, it's still a procedure. It's a low risk procedure, but there's still potential for, like you said, if you perforate the colon, you end up with stool in your belly, you end up with sepsis, then that's you're high risk at that point. You're gonna have to go to surgery. You're high risk for whatever complications come after that. But the number of patients that happens to compared to the number of patients where they're catching cancers early or it doesn't happen to at all is not even comparable, right? So you can still safely say everybody in here needs to be getting routine colonoscopies based on what your primary care physician recommends. You're saying what? Oh, local. So it's going to be based on what they assess you for, right? So if you're someone that's waking up mid colonoscopy over and over again, I wouldn't want to wake up during my colonoscopy personally. But if you're someone that's waking up mid colonoscopy and you pose a risk to the completion of the procedure or pose a risk to yourself, then they may have to give you something stronger, right? But you would hope that some people you can give a little bit of Ativan, which is just like a little sedative, like a couple shots of tequila, and they're out. Okay. All right. So quick live scenario. Oh, go ahead.
All right. I just wanted to address someone asked about choosing the right doctor. I don't know why it is, but typically Black men, if you're sick, you want to hide it. Okay. I found when you talk about it, in my club, when I got prostate cancer, after I start talking about it, I found out that there were a number of people that had prostate cancer, okay? Which means that they had a urologist that they had gone to that you could have talked to and see what kind of outcome that, how it came out with them. And then you'd have that referral. It's like anything, even fixing your house, painting or whatever, you ask for someone or someone that's been used that that did a good job for you. So that's how you use it. But we've got to talk more. You know, just because we're sick, we shouldn't just try to hide it. I mean, if we talk more about it, we'll find out more as far as people that are successful and haven't gone through the same thing that you've gone through. You know, and so that's been my objective in my group with the Atlanta Pro Duffers. We have a membership of about 66, is try to encourage you to talk more about things that's going on with you, you know, and that way people won't have to go through the same thing that maybe you went through. There's some things that went on with me through my going through prostate cancer that I share with other people. And then I find out, you know, that some of them have gone through the same thing and some of them had same physician, had same results, whatever. So
Talk about
yeah.
Amen.
Good point.
So I'm gonna move on to this live scenario, and I'm gonna pick on my uncle's table here. I'm gonna use them as my guinea pigs. But anybody at the end, anybody can call out what they understand. So essentially what I'm gonna do is I'm gonna describe a patient that's coming into the ED with a problem. And then I'm gonna be the surgeon that comes to see them, and I'm gonna consent them for surgery. Now you have to do your best to understand what I'm even talking about, to understand what I've just consented them for. Okay? And so that's going to be you guys' job. Is I'm going to say a bunch of medical terms about type of this procedure you're going to get, the outcomes and things like that. And you have to tell me in layman's terms that everybody here can understand what procedure is getting done. Okay. How many people in here have had surgery before? Yeah. Okay. So we have some experience in here. Let's see. So this patient is a 65-year-old male, history of smoking, a little alcohol abuse. Let's not say abuse, let's say use. Couple bourbons every now and then. Smokes a couple cigars every now and then. Okay. Has high blood pressure that he takes medication for, has diabetes that's well controlled, not on insulin. Okay. He presents to the ED with abdominal pain and some rectal bleeding. He's had some issues with constipation the last couple of weeks, doesn't think anything of it because he'll have diarrhea every now and then, but now his abdominal pain has gotten severe and he has some rectal bleeding. The ED docs do a CT scan on him, take some images. They do a rectal exam, which is standard, just so everyone knows, a rectal exam is standard for rectal bleeding. Okay, have to make sure it's not hemorrhoids. And the surgeons come and determine that he needs surgery for his colonic perforation, and he potentially has some type of obstructing mass that they suspect is cancer. Okay, so now I've just walked into you guys' ED room, and I'm going to consent you for surgery. Okay. Hello, sir. My name is Dr. Williams. I'm here to consent you for surgery. Okay. I'm going to consent you for a diagnostic laparotomy, potential resection of the colon, potential exploratory laparotomy, okay, potential ostomy, potential ileostomy, potential small bowel resection, okay, and we'll leave it at that for right now. Okay, the risk of this surgery are infection, pain, and bleeding, with the possibility of death. Okay. The expectation is that after surgery, you may spend some time in the ICU, and then ultimately you'll go to the floor, and ultimately you'll be discharged home if everything goes well. From what I've just told you, kind of go back to our local risk mnemonic. Okay, what have you gathered from that? What type of surgery are you going to get? What are your expectations? Yeah.
They're doing a reset.
Mike's.
Oh man, I'm excited to hear what you guys came up with all this one.
Yeah.
I said if they're doing a resection, they're going to be taking part of the colon,
Right.
And then after that, you might have maybe that will decrease the bleeding and stuff like that. But they are going to do some type of removal of certain organs.
Right. Certain organs.
Certain organs.
Yeah.
Basically,
Yeah.
if they're getting, you talked about the bag afterwards. That means you're going to have a bag to collect the waste and all of that once they've done the surgery.
Anybody else want to weigh in on that? Yeah.
So I would ask, I didn't understand anything you said,
Yeah.
except that I'm going to have a surgery. And the first thing I would say, can I get a second opinion? And then tell me in layman's term what you're going to do, because I didn't understand a word you said.
So in these instances, I think it's safe to trust the opinion of the consulting surgical team, especially when you're extremist like this. So you're presenting with an acute abdomen, which means you have active abdominal pain. They've diagnosed you with a perforation, which means you have stool on your abdomen. You can get very sick very fast. Okay. So the second opinion stuff happens typically if you say you catch something, way before you need some type of surgery and you don't trust necessarily your surgeon's opinion. Okay. Which shouldn't be that often. Like the second opinion shouldn't occur that often because your primary care doc is referring you to somebody that they trust. Okay. So it shouldn't happen that often. And if you're going to, if you're talking with friends and things like that, you've kind of got some feedback about like who the local surgeons are and things like that. So it shouldn't occur that often. But in this instance, right, the first thing I would say to the doc is you have to say that in layman's terms. What does any of that mean? I said a diagnostic laparoscopy. Who knows what that means? Some folks may, but not most. Not most
So
folks.
diagnosis by proxy.
Yeah, no. So diagnostic laparoscopy means I make a small incision in your abdomen.
Okay.
Probably around your umbilicus, small incision in your abdomen, and I stick in a camera. So I get to look in your belly with the camera before I make a big old cut to see what's going on in there. Okay. Then I said possible exploratory laparotomy. And we say that because if I look in there and I see stool everywhere, right, and you actually have a perforation or I see blood, I see bleeding, I see something bad in there, then we're going to have to open you up. That's the only safe way to do it. We open you up, we're able to wash you out, things like that, right? Place your drains and things like that. So that's why you have a possible exploratory laparotomy. If you present with, disease process like that, it's a good chance you might get a big cut. So it's possible. The way I would say it is, this is worst case scenario. I always think in the worst case, this is probably potentially what's going to happen. I expect this when I wake up from surgery, I might have a big cut on my belly. Okay. I said possible colonic resection. In this case, it's most likely going to be colonic resection, which means I'm going to take out part of your colon. Okay. If you can say, do you know what part of the colon you're going to take? You're going to take my entire colon out? What's the standard of care here? If they suspect cancer, they're going to take a lot more of your colon than they would if it's just, I don't know if anyone's heard of diverticulitis. Anyone had diverticulitis in here? Yeah. They'll take a lot more of your colon if they suspect cancer in case there are nodes and things that they need to get. Okay. So when you hear colon resection, you say, okay, how much of the colon's gone? You can live just fine without a colon, by the way. You can live just fine without large portions of your colon. It's when you start removing the small bowel that you start having some issues with malnutrition and things like that, okay? And so for anyone who doesn't know, food goes down your esophagus to your stomach, to your small bowel, okay? Then it goes into your colon. And that's where things start getting concentrated. It starts forming the stool. Everything before that is kind of just loose fluid, nutrition, and things like that, okay? Complications after a colon resection typically are diarrhea. You get some diarrhea afterwards, okay? And after a while, your body gets used to it and it starts to thicken that stuff up and you go back to normal stools. So you can live just fine. There's probably people in here who don't have portions of the colon now. You live just fine without portions of your colon, okay? So I said possible colon resection. I said possible small bowel resection. And then here's the kicker here. I said possible ostomy. Now, if you didn't catch that when you signed that consent form and you woke up with a piece of your colon attached to your abdominal wall or your stool coming out of your skin, that could be very alarming, I'd imagine, right? So it's very important that you ask every part of that consent and you go back to here. Where's the surgery going to happen, doc? So if you do the diagnostic lab, it's going to be right above my belly button. If you do the big cut, it's going to be right here down the midline, okay? Well, if you do this ostomy, where's it going to be at? Okay, they need to mark it in the right place, right? Because if you're sitting up, you don't want your ostomy to be squished down. You got stool spilling everywhere. You want it to be in the right place. So location matters, okay? And then I also said possible ileostomy. Like this different from the ostomy. Because like I said, in the colon, you concentrate your stool. When you use the restroom today and you have that stool in the toilet, that's because it went through your colon, it got dehydrated, there's less fluid in there. If it's coming straight from your small bowel, it's all diarrhea. That's a completely different beast than an ostomy, right? Ostomy, ileostomy, two completely different things. You have one thing that's going to be basically fluid. You have one thing that's going to be stool. One's a lot harder to manage than the other. Doc, what's the chances of me getting an ileostomy versus ostomy? These are things you gotta ask, right? And you're just going through the things. So then you're going through the operation type, right? They're going to put you all the way down for this type of procedure. They're opening the belly. There's no local option here, okay? The complications are high because it's emergent surgery. Anytime you do emergent surgery, complications are high, which is why I would rather take the risk of getting a colonoscopy and whatever small percentage, chance of me having a complication from that colonoscopy versus the complications and risk that come from doing an emergent open procedure. Very high risk procedure. You have an unprepped colon, so you have the chance for a lot of stool to get around in your belly. You have the chances for infection afterwards, right? You have the chances for developing sepsis and things like that, like we talked about before, and your buddy that passed from sepsis and rest his soul. You have a higher risk of that happening, okay? And so going through this pre-op must-knows kind of gives you an idea of what you're going to go through in the surgery. I know I got to keep moving. I'm going overtime, okay? All right, quick. Anybody know who this is? Marcus Russell. You don't want to be Marcus Russell. Anybody know who this is? Patrick Mahomes. So, arguably one of the most talented quarterbacks of all time, and then arguably the greatest quarterback of all time. But one more talented than the other. In my opinion, Patrick Mahomes is much more talented than Tom Brady could ever be. But Tom Brady was a fantastic game manager, right? And so that's what we're talking about here. Anybody know who this guy is? Stetson Bennett, starting quarterback for UGA. What? I was saying, yeah, he's about 50 years old. He should be in here. But Stetson Bennett is about 5'9", 195 pounds. He might end up working at Canes if he doesn't get drafted. But he was a game manager. The reason why he did so well at UGA is because he was a game manager. And so that's what you have to be for your body. You have to be able to manage your body. Just really quickly, we'll go through this. So medical history. You got to know your medical history.
Right.
Have it written down. Have a file, have a document, have something. There's so many men that come into the clinic. My wife knows. My wife not here today, so what we're going to do? I have no idea what's going on, okay? Got to know your allergies. That's a simple thing. If I take this medication, my face blows up like a balloon, okay? Necessary information, things the thing that brought you into the clinic in the first place, all right? You ain't coming in to talk about your knee that's been bad since 81. You're not there to talk about your elbow that's been swollen up. You're there because you're having chest pain. Necessary information that you have to make sure you're sharing that with your doc, okay? And then you're getting information back. So you're giving information, but you're getting information back. You got to make sure that you're not leaving your clinic or the ED without the answers that you went there for, okay? And then from getting that information, they're giving you an explanation that makes sense to you. You're not still curious when you leave, right? So I asked my dad, after he leaves the doctor's office, he's been asking about his A1C, seeing if his glucose is high and things like that. And you asking me questions afterwards. Why are you asking me questions afterwards? You should have gotten that explanation in the clinic. You shouldn't have left until you got the explanation in the clinic from your physician, okay? And then, of course, what you should be doing after you leave the ED, after you leave the doctor's office, rest and recovery. They tell you need to work out for 30 minutes a day, work out 30 minutes a day. They tell you need to, take more steps, do whatever you need to do. You need to be doing that. So you're a game manager. All right, next, this is for the people who are patient advocates, which I think all of us really are. If you got aging parents, you got a wife, you got a spouse, you got whoever. There's worksheets that they passed out. Am I right, Dr. Parker? The worksheets? Yeah. I just want you to take out your phone, take a picture of the worksheet, because I know 80% of these worksheets going to end up in the trash can. Take a picture of the worksheet, and there's an option on your iPhone to put a heart on it. You can favorite if you have an iPhone. I don't know what it is on the Droid, but you can favorite it. That way, you got the picture in your phone, and you have it in your favorites album. This is a quick and dirty way for you to be able to be a good patient advocate if you or a loved one is admitted to the hospital. You have your doctor's names on there. You have the nurses' names on there. you have the room number, you have the hospital, so that when you either go back to clinic or if you're talking to somebody else about what's going on with your loved one, you have the basic information. Okay. Take a picture of it, keep it in your phone. 'Cause I know the paper, if you like me, the paper's it might hit the recycling bin when I walk out. Okay. All right. And lastly, just talking about some of the common surgeries. So a lot of folks in here may have had some of these surgeries. The only ones that I do on here are the hernia, the cholecystectomy, which are gallbladder surgeries, and then colorectal incisions for removing parts of the colon. So those are the only surgeries I do in here. But these are common surgeries. You got to have some idea about the nature of these surgeries, especially if you're going to get them. You can look into them prior. A lot of these are elective procedures. I would say most of these are elective procedures besides the colorectal surgery. Sometimes you present like the patient did before and you just need surgery. Okay. What questions can I answer?
Can you get a mic over there?
Yeah.
Brain degenerative diseases.
Yeah. So I'm going to admit that that's not my wheelhouse, that I like to cut on people and I didn't like to look at brain pictures. And that's why I didn't go into neurology. But I know that there's strong correlations between head trauma, concussions with neurodegenerative disorders. I don't have a full stance on medical cannabis yet, mainly because it hasn't been studied enough, because it's been classified as such a high level drug that a lot of labs, even when I was in undergrad trying to study some of these things, a lot of labs couldn't have access to marijuana. And so, you know, the amount of good level 1 information that says, yes, I would 100% recommend this to a patient just isn't there yet because it hasn't been studied yet. And how variable cannabis is as far as its concentration, as far as its psychoactive properties, you know, we're just not at a place where I would feel comfortable recommending, you know, just say, go use marijuana for whatever ailment. We're not at a place that we can do that yet, like we can with other drugs. Yeah.
Gentleman back behind you, Mr. Robertson.
Okay, can you hear me?
Yes, sir.
I just had a colonoscopy yesterday. Propanol, I had for the anesthesiologist. She told me that this is what Michael Jackson went out on. But anyway, is there any long-term effects from using it?
Yeah.
Say mental, whatever?
Yeah, so it wears off relatively quickly, the effects of propofol. So, you know, I think what we really worry about is like the acute side effects. So like once you go under, if you have the issues with your respiration, which means you stop, your brain tells your body to stop breathing, you stop breathing. So the acute issues is what we worry about. Now, if you're in the ICU and we had you on propofol for a week or so, then we worry about there's some side effect profiles there. But after you come off the drug and it's already out of your system, I think you're pretty much in the clear.
For Dr. Parker, what are the likely causes of a brain clot?
Of a brain clot? Blood clot. Oh, blood clot. A blood clot. Yeah. That's another thing, a complication that we didn't touch on, but it is pretty common after surgery for folks to have blood clots. I know that you guys have probably heard that before. And what sometimes you do, depending on how high risk the surgery is, they put you on a blood thinner afterwards, right, to prevent that. You know, there's still a lot of research being done as to, you know, why they develop in some people and don't develop in other people. We know that some people are at a higher risk. Obese people are at a higher risk. Sometimes women on certain medications, or estrogen and things like that, are at higher risk. But, you know, developing causes. Oh, yeah. I mean, so blood pooling. So if you have like venous stasis, so your blood isn't moving back and forth in your legs, if there's some sort of injury or trauma there to the blood vessel, things like that can potentially cause the blood clot. Induction of anesthesia can be a cause for the formation of the blood clot. So that's why we put, if you've seen folks in surgery, you get like a wrap around your legs that's like squeezing and compressing your legs. That's to keep blood moving back and forth. Yep.
Yeah, Dr. Williams.
Yep. Where am I looking?
Hi. What's the 1 or 2 things we could do for ourselves so that we don't end up needing your services?
Yeah. Keep me in the poorhouse, I see. So I would say most of the issues that we treat that become surgical issues, one of the main causes of that is obesity. And so I think it sounds trivial, but doing that 30 minutes of aerobic exercise a day really helps. I don't know if y'all saw the picture of my dad up there, but the picture here in the yellow, where he has a little pot belly, is about 5 years ago when he was still actively working in corporate America and stressed out and things like that. And the picture on the left is just last year for my mother's 60th birthday. And he's lost about 20 to 30 pounds. So he's around 185 now, right? So for someone 6 feet tall, around 185, that's a good weight for him. And so his chances of having hernia are exceptionally low. His chances of presenting with gallbladder disease because of his diet and exercise are low, right? And then he goes routinely to his PCP, gets his colonoscopy. I think they both just got their colonoscopies 2 weeks ago. And so he's very health literate and stays up on his health and he stays healthy. And so him seeing me is very unlikely on the left, much more likely on the right picture.
Hi.
Yeah.
I was a military nurse and I used to work with a gastroenterologist. And one of the things I remember him saying to this day, and I've been retired now almost 28 years, but he said that he give his patients medications because they won't follow a diet.
Yep.
If they would only follow a diet, some of the medications they would not have to take.
Yeah, I agree 100%. And diet is easier said than done, as a lot of us know. Y'all eating at lunch today, I see.
It was a good lunch.
Yeah, okay. Well, it's easier said than done, right, with the diet. And so I think if you find something that's healthy and that you can stick to, then that's good. I just got engaged a couple months ago. So my fiance is getting me in wedding shape, quote unquote. And so she's been making some pretty good dinners that are very healthy, right? She's been limiting carbs. There's no sweets in the house, the things I love and would rather eat. She stopped frying stuff. So you can make.
That's a good start.
I know she's trying to make. I'm trying to make it to your age, you know. I'm trying to make it to your age, but that's the thing. You can make it. It's a lifestyle change. It's a lifestyle change, and if you can change your lifestyle, be more healthy, then you're going to live longer, and you'll have a better quality of life.
Just a real quick question about consent. I'm over here. Consent with people whom you might have power of attorney for, meaning someone who could possibly be at the last stage. My experience as a caretaker, my mom was at that point. She was bedridden, and the doctor wanted to do a colorectal cancer procedure on her, meaning surgery.
Yeah.
And at what point do we look at improvement of quality of life versus consenting to something just because it's available?
Huge. That's a major question, because I think most of us in here either will go through that, unfortunately, or have gone through that, where we've been the power of attorney for somebody, and it seemed like, we want them to live, we want them to be okay, but it doesn't seem like their health is declining, they're older, things like that, and you're trying to make a good decision based on what you would want for them, and potentially what they would want for themselves versus what the reality is, right? And so it's not an easy decision. I had to do it for both of my grandmothers, and I've had to help other people do it. But there are certain points where you're in a certain stage of life where it's time to go. And you have to ask yourself, is the procedure, the surgery, medication, or intervention going to meaningfully prolong their life? Or is it going to be some type of cruel existence for a period of time? If someone's bedridden, if they're not speaking, they have dementia, they don't know who you are, they don't know who they are, I wouldn't cut on that person. Sometimes when it's your time, you can go gracefully versus you leaving this earth with drains, tubes in your mouth, and big surgical incisions on your belly. And I think that's a very difficult conclusion to come to. A lot of people have issues with that, whether it be religious reasons, or they don't necessarily understand some of the medical and health side of things. But it's a very difficult point that you make. And unfortunately, a lot of us will have to deal with that at some point, and our family members will have to deal with that with us at some point. I think for an important point to make, and before I turn it over to Dr. Parker, who's kicking me off now, is a living will is important. So saying what you want in your final days, if you were to get very sick when you leave this building, your family shouldn't be guessing what you would want. Your family should know, because you've had discussions with them and because you have it written down. Don't let them doctors do CPR on me 50 million times and break all my bones and ribs and sternum. Don't let them put a tube down my throat where I'm dependent on a ventilator for the next 60 days, 90 days. I'm getting pneumonia. I'm confused. I'm just in constant pain. They have me sedated on all these drugs and medications. Don't let me go that way, right? I would rather go with some dignity in my house, in my home, in a rehab facility, however else, versus the fate that you could potentially have in the ICU bed. I've worked in ICU. I was in the ICUs throughout COVID. And it was one of the darkest periods of my life because all I saw was either people on death's door, death itself, or families having to deal with their loved one, their impending doom of a loved one, and how they had to wrestle with that, and how they had to wrestle with religion, how they had to wrestle with common sense, how they had to wrestle with other family members. Take that out of everyone's hands. Don't let them feel guilty for what happens. You make a living will, you have an advanced directive. You say, if this happens, if there's no meaningful recovery from this, if the doctors assess and say there's no meaningful recovery, then you let me go gracefully. I think that's very important that everyone does that. And that might be the biggest takeaway today, honestly, is a living will and an advanced directive, making sure that your last wishes are respected. I think that's huge.
Excellent.
Okay.
Thank you, Dr. Will.
Thank y'all for the opportunity.
So I've got to get Jeroson, because he's got a couple more people who are in training with him to come give us a talk and answer questions.
Yeah. So
Thank you,
I'll
Dr.
bring
Williams.
some GI docs, some colonoscopy docs in here and let them talk to y'all too. All right.
Thank
Y'all
you.
for the opportunity.
So I'm going to reiterate that one of the things that we'd like to do for you, if you had some questions that weren't answered today, on Monday, we're going to have a call-in for those of you who are here to speak with Dr. Flowers, Mr. Dorbin, Dr. Dye, and Mr. Graves to answer any questions that we couldn't answer. Dr. Flowers, our cardiologist, is going to try to answer as many medical questions as possible. I'm not sure whether I'm supposed to be a part of that or not. This is supposed to be a men's discussion group. I only do what they tell me to do. So you don't find that hard to believe, don't you? But I really do what they tell me to do. So right now, we want to reward you for your participation. And hopefully you've gained some information, some insight today that you can use to your benefit or that of a family member at some other time later to this. But hopefully you remember something.